Welcome everybody to University of Miami. It's delightful to have you down here and to be able to host this day down here. So I guess as the first point of clarification, does everybody know what atrial fibrillation is? If you don't raise your hand, I'm going to assume no and have to explain it. Does everyone know what it is? Raise your hand if you know what it is. Okay.
You explain.
Explain it. Okay, good. So atrial fibrillation is really the most common heart rhythm disorder that's treated in the United States. I'll give you my poor man's demonstration. Everybody knows there are four chambers to the heart. There are the upper chambers, the lower chambers. The upper chambers are the atria, and the lower chambers are the ventricles. So those are the main pumping chambers. And the way the heart beats is the upper chambers contract and then the lower chambers, right? So you're sort of lubbed up, right? So you get upper chambers contract, lower chambers contract. What drives that is the heart's electrical system. So the upper chambers have an electrical depolarization, and then that leads to an electrical depolarization in the lower chambers, which causes a contraction. One here, one here. What happens in atrial fibrillation is the upper chambers go crazy, and they go at 400 or 500 beats a minute. Now, obviously, if the lower chambers kept track with that, you would die. But fortunately, the heart has a good way to accommodate to that, and it blocks many of those impulses from getting through. But nevertheless, there are many, many different sequelae of having that atrial fibrillation, ranging from symptoms, risk of stroke, and that's what we're going to start to talk about. Does that help for those? Okay, great. So the couple important statistics to know about atrial fibrillation is your lifetime risk for developing atrial fibrillation is approximately 25% once you reach the age of 40, okay? And that doesn't matter what age you are, beyond 40, you still have a 25% risk of developing AFib sometime before you die. Currently, it affects over 5 million Americans. It's projected to affect over 12 million by 2050. And what's really important is that 15% of strokes in the United States are attributable to atrial fibrillation. What's the sad part about this slide is that the best treatment that we have to restore normal rhythm is catheter ablation, which is a procedure that's done transvenously. We put catheters into the heart and we try to find the sources of the atrial fibrillation. But if you look at the success rates that are published in the literature, it's only about 50%. That's the best that we are able to do. So I'd like to sort of give you an overview of the landscape of the issues and problems that we have with atrial fibrillation and how we're trying to address some of that. I'm not going to tell you how to do a diagnostic evaluation for atrial fibrillation, but I really put up this slide. This is the guidelines that were published in 2014. There's been a recent update in 2019, but the initial evaluation has not really changed. That was recommended in these guidelines. And what's really interesting, the basics are taking a history and doing a physical examination, doing an ECG, an echocardiogram, and blood tests. This diagnostic evaluation has not changed in over 30 years. This is exactly the same diagnostic evaluation that was performed when I was an intern many, many years ago. And the question is why? Why have things not advanced to the point where we can do more fancy diagnostic evaluations? Just think about the diagnostics in cancer, for example. The diagnostics in cancer have led to opening up the therapeutic realm, and we have made zero advance in atrial fibrillation. Now, I don't want to leave you with the notion that there have been no advances in atrial fibrillation. This slide sort of lists a lot of the different advances that have been made, mostly in the therapeutic area. There are a lot of new blood thinners, anticoagulants, some new antiarrhythmic drugs, a lot of new technology for catheter ablation, for left atrial appendage closure, which is another type of procedure. And if you look at what's common to all of these, and these are all wonderful advances, but these are all advances that have been developed by industry. They're great, they're wonderful, but they don't help us with the diagnostic piece in terms of figure out which patients are appropriate for which of these therapies. We have no concept of how to match treatment, these wonderful treatments that are now available, to the individual patient. Now, there is one new recommendation that came up in the 2019 guidelines, and this is about the most low-tech intervention that's possible. And that's worth reading here. It's for overweight and obese patients with atrial fibrillation. Weight loss combined with risk factor modification is recommended. Okay, this was not developed by industry. This is based on a lot of research from groups in Australia, but this is not associated with generating any great financial return to anybody. And the question is, how do we leverage this important finding and try to implement this in our current environment? So just briefly to show you the kind of work that's been done here, this is one of the studies that's from the Australian group where they basically tried to look at the effect of weight reduction on symptom burden and symptom severity of atrial fibrillation. These are the slides up here. We'll just focus on a couple of these. This is looking at the body mass index, which is sort of another parameter for looking at weight. And when they try to do aggressive risk factor modification and weight loss, you see a much greater change in the BMI compared to the other arm, which basically says you're overweight, go figure out how to lose weight. And that's the way most doctors, treat their patients. If you look at the effect of this weight loss on the atrial fibrillation symptom burden or symptom severity score, it doesn't really matter. You can see that if you lose weight, your symptoms for atrial fibrillation improve dramatically. And that's really the basis for the recommendations in the new guidelines. And this is one other study from that same group, and it's just looking at how much AFib they have, atrial fibrillation they have after catheter ablation. So after that procedure that I told you has only a 50% success rate. And they looked at three groups here. These are people who basically lose more than 10% of their weight. These are people who lose 3 to 9%, and these are people who lose less than 3%. And you can see the more weight you lose, the better your outcomes are from atrial fibrillation. You do much better. And on average, it's probably around 50% because most people don't lose this kind of weight. Now, I don't have to tell the people in this group, anybody who picks up the paper, you see graphs like this all the time that basically show the prevalence of obesity and diabetes in the United States. Unless you live in Colorado, the prevalence of obesity is well over 20%. And obviously there are a lot of regional differences, but these are actually huge, huge problems. And I'm sure this is a major contributor to the rising incidence of atrial fibrillation. So some of the work that we're doing is trying to leverage off of this finding. So why does weight loss actually help? We don't really know. But one of the things that we're thinking about is the fact that fat tissue exists all over the place, right? You have it in your stomach, and it turns out that you also have it on your heart. This fat tissue sits right on the muscle, and this fat tissue can secrete all sorts of bad humors into the heart itself and create fibrosis and inflammation and a lot of the factors that lead to atrial fibrillation. And our approach has therefore been to try to actually target this and to see if we can pharmacologically affect this epicardial tissue. So this is a study that we just initiated in the past year that's funded by the National Institutes of Health. It's called the LEAF study, liraglutide effects on atrial fibrillation. And liraglutide is a medication that's used for both diabetes and obesity. And we have taken it on and are now using it for atrial fibrillation. I don't have a lot to share with you, except basically what we do is we take patients who are going to have a catheter ablation procedure for atrial fibrillation. They get randomized initially to just that risk factor modification program, like they did in Australia, or the other group gets this risk factor modification plus the liraglutide, and then we try to see how they do after the ablation procedure. What's very interesting, so far we've had 6 patients that have reached the 3-month time point, and this is just looking at weight loss. You can see if you're in the risk factor modification group, you lose some weight, you lose a little over 1 kilogram, but if you're in the liraglutide group, you lose almost 7 kilograms in 3 months. So it really has a profound effect on weight. I don't have the data here to show you, but it also dramatically reduces the fat around the heart. We've already done the analysis showing that the liraglutide has a dramatic effect on that. So we're hoping that that will translate into a tangible effect on atrial fibrillation as well. One of the next major areas that we're concerned about is the risk of stroke in atrial fibrillation. And currently, the way we assess a patient's risk for stroke is we look at a variety of different clinical factors. Do they have high blood pressure? Do they have diabetes? Are they old? And we add all these risk factors, and based on the number of risk factors they have, we say, yes, you're high risk and you should be on an anticoagulant, or no, you're not high risk enough and you shouldn't be on an anticoagulant. People have looked at a variety of different risk scores, and the only thing I need to point out to you is if you look at these numbers, they're all in the range of 0.5 and a little bit. And what this number here, the C statistic, tells you is how predictive these risk scores are. So a risk score that has a predictive value of 1 is perfect. A risk score that has a predictive value of 0.5, you may as well toss a coin. It's 50-50. And you can see that all of these risk scores are essentially just slightly better than a coin toss. And that's the state of the art for treatment in atrial fibrillation. And if you look at it, it makes a lot of sense. Okay, what does high blood pressure actually have to do directly with forming a blood clot in the atrium? It has nothing to do with it. And any one of these risk factors, it's good for looking at populations. Yes, when you look at a big population of patients, the more sicker you are, the worse you're going to do. Everybody knows that, right? But if you look at an individual patient, how do you make that choice? And I think the best way to show that to you is, with these 2 examples. So if you consider first the 70-year-old obese male with a 25-year history of high blood pressure or hypertension, requiring multiple drugs, this person never exercises. So this person in our scoring system for age of 70 would get 1 point, and for the blood pressure would also get 1 point. So they'd have a risk score of 2. Now consider this person's cousin, who's also 70, but fit male, whose doctor first diagnosed mild high blood pressure last year, and he continues to run 6 miles per day. If you calculate the risk score for this person, he's also 70, so he gets 1 point. He has high blood pressure, gets another point. His risk score is exactly the same as the first one. Now, does it make sense to anybody in this room that these 2 patients with atrial fibrillation would have the same risk? No. It doesn't make sense to me, but that's why our risk scores don't work very well, because we treat them the same, even though they're clearly not the same. So how do we try to get this better? So one of the ways that we're trying to do that is with this technique that we've developed called 4D flow MRI. So this is an MRI of the heart, and what you're looking here, so this is the sort of a slice in the upper chamber of the heart, and what you're looking at here, color-coded, are the velocities or the flow velocities of the blood in this atrium. And when you get to be red, those are the high flow velocities, and those are good. If you have low flow velocities, as you'll see in a moment, that's not so good. So this slide and the next one will be these 4D flow MRI pictures from patients who have the exact same risk score based on our clinical risk score. So again, you'll see a lot of red over here, And in the next one, see if we could get it to go right. Okay, so here's the next one. You can see that the colors here are much less. You don't get anything up in the red and the yellow. It's mostly in the green range. So you can see, even though these two patients have the same risk score, the blood flow, the flow velocities here are much less. And when you have blood doesn't flow very well, that's when it leads to blood clots and can lead to stroke. So we think that this could be a new advance in trying to figure out who's at risk for stroke. And just in general, I think what we've done is we've tried to look at atrial fibrillation in a little bit different way than we looked at it when I first started training. So when I first started training, we said, all right, let's consider what to do for the patient when they get atrial fibrillation, when it's manifest. Okay? Then we can start to address their risk for stroke and et cetera, et cetera. But now I think what we have to do is we have to go backwards. What are the factors that are leading to somebody getting atrial fibrillation? Just like we know when somebody has a blockage in their artery, it didn't happen today. It's a process that's happened over many decades. Well, atrial fibrillation is no different. This is a process that's been going on for decades, and we have to figure out how to figure out what's going on here and how to intervene early. So what I'd like to do is just close up with a couple of just a quick description of the studies that most of them I've already given to you. For stroke prevention, we're really looking at this 4D-flow MRI to try to improve prediction of who is going to have a stroke. I told you a little bit about our LEAF study, which I think is going to be a really novel and new treatment for patients with atrial fibrillation. And then the last thing that we're doing, which is also funded by the NIH, is we've developed a new mapping technology to try to pinpoint where to actually deliver ablation lesions for patients who are having catheter ablation. So I mentioned that the success rate for catheter ablation is 50%. And part of the reason that it's 50% is because we don't know where to ablate. We actually guess, to be quite honest. And that it's an educated guess. The educated guess is based on a lot of work that's been done in the field. And we know where a lot of atrial fibrillation comes from. But a lot of atrial fibrillation comes from other places, and we just don't know yet how to identify that. The techniques that we have for ablation for other arrhythmias to locate exactly the precise spot where the arrhythmia is coming from don't work in atrial fibrillation. So that really led us to try to develop this new kind of mapping technology that really looks at a different parameter of the signals that we get from the heart that allows us to pinpoint that. So it's really an exciting area. I think the landscape of atrial fibrillation, as I tried to paint for you, is really leaves an open book to try to improve both our diagnostic and therapeutic platforms. We're excited here at the University of Miami to be able to lead in some of these studies and to try to help solve this problem. So thank you very much.
Switch over to Dr. Collins.
Here's your clicker.
Thank you very much. Thank you so much for coming. The topic of cardiovascular diseases in Hispanics is very dear to me. Those were my first research projects when I was a fellow about 20 years ago. So it's interesting because we need to understand a little bit of the background of the presence of Hispanics here in this country, and they have been here for a long, long time. So we know that many states have Spanish names like Colorado, Texas, California, Arizona. even the 1600s, before the Pilgrims landed in Plymouth Rock, mestizos from northern Mexico were already here in what is now Santa Fe, New Mexico. Spanish-speaking settlers also arrived to Texas in the 1700s and to California and Colorado in the 1800s, and those territories anyway belong to Mexico. And then the oldest city under the American flag remains San Juan, Puerto Rico, that was founded in 1521. So that's I think gives us a little bit of what the landscape is. So who is considered Hispanic or Latino? When I started this to look into these topics, we didn't really understand. So I came from Argentina. My ancestors are Central European. Actually, my daughter did the 23andMe and found that she's 99.6% Ashkenazi Jew, and the other 0.6% is broader European. So I never considered myself a Hispanic. And then I'm coming from Argentina, so that's a non-issue there because we're all Argentinians and we all speak Spanish. But then here in the States, even though I may have the same genetic composition of as Dr. Goldberger or Dr. Myerburg, I'm Hispanic because of a cultural heritage. So the term Hispanic is a relatively artificial term. It was just coined by the Office of Management and Budget in 1977 to standardize data collection and to provide a common denominator to a very diverse population. So the rule of Hispanic is just is somebody who self-classifies him or herself as one of these different categories: Mexican, Puerto Rican, Cuban, and other Spanish, Hispanic origins. So, for example, Brazilians are not Hispanic because they speak Portuguese. And then the other thing is that the lack of here in Miami is a very special place. It's like being in Latin America. But other places, like in North Carolina or other more rural places, they have no idea of what Brazilians speak and whether Sao Paulo is the capital of Argentina or Buenos Aires is the capital of Peru. So there's also a lack of knowledge. And then Hispanics can be of any race. So this classification was revised in 1997 just to change the term to not from Hispanic to Hispanic or Latino, because some regions call Hispanics Latinos and some other regions call Latino Hispanics. So just to make sure that everybody is inclusive. So the U.S. Census Bureau relies only on self-reporting. So, for example, in the 2020 census, the form will ask the question in this way: is this person of Hispanic, Latino, or Spanish origin? And then you have, you can say no or yes, and you have all the different other categories. And then if you are not Mexican, Puerto Rican, or Cuban, then you can say if you are of any other origin. So in summary, who is Hispanic? Anyone who says they are, and nobody who says they aren't. And in the right-hand side of the slide, you can see that the Hispanic population has been growing steadily since the 70s. In 2003, they became the largest minority in this country, and it's projected to be about 60 millions. It's already reached 60 millions in 2018, and it's expected to grow even more. So how is the Latino population conformed in this country? So as you can see in the pie chart in the left-hand side of the slide, 65% of Hispanics are of Mexican origin, followed by Puerto Ricans 9.2% and Cuban 3.7%, and you have a number of other different nationalities. If you look at the age distribution, so it's a relatively younger population as opposed. So this is like the age pyramid. So it looks like a triangle, and when you have more age populations, it looks like a square. So you can see that most Hispanics. Here you can see I can use this. So you can see here that most Hispanics are relatively young, and the majority even younger than 40 years of age. So This is what the census tells us. So in terms of their socioeconomic status and how much they work, it's been shown that in different surveys and the census that Hispanics have a lower income than non-Hispanic whites, and yet there are most of them tend to be employed. The majority of Hispanics in the U.S. are employed, about 65%, similar to the rate for non-Hispanic whites. However, the type of jobs that they engage are usually higher risk for and low social position occupations, especially for Mexican Americans and for Central Americans. And if you compare here non-Hispanic whites with Cubans, you can see that the type of works they do is similar in these two different categories. But it's important also to divide the Hispanic population by the different subcategories, because they are very distinct. Their socioeconomic status is very different, and their degree of acculturation and education is also very different. So Hispanics in the U.S. workforce, they are very productive. Latinos in the next 8 years will represent more than 75% of labor force growth. By 2024, 1 in 5 workers will be Latinos, and more than 28 million Latinos are already in the workforce. So, and then it's going to be 30% in 2050. So that has incredible influence on the economic development of this country. And then if you see in this nice slide, so you can actually calculate the Latino GDP. And then if you compare the Latino GDP, that is about $2.1 trillion. So it's actually lags behind countries like China, Japan, Germany, the UK, and France, and it's ahead of India and Brazil, for example. So it's very interesting. So Latinos also, in terms of healthcare, in terms of cardiovascular healthcare, you can see the cause of death for the different different conditions, and you can see that Latinos are most likely to die of cardiovascular disease, followed by cancer, accidents, and you can see here the difference in men and women, then diabetes, Alzheimer, and chronic liver disease. So cardiovascular disease, as is population growth, cardiovascular disease takes a central role in the care of Latinos. In terms of risk factors, the cardiovascular risk factors include hypertension, diabetes, hyperlipidemia, obesity, and other non-traditional risk factors, such as the calcium in the coronaries or the C-reactive protein. But talking about the traditional risk factors, we have hypertension. Usually we look at hypertension as awareness, treatment, and control. And you can see that the awareness is about the same in the different in between non-Hispanic whites, non-Hispanic blacks, but it's slightly less among Hispanics. And then if you look at the treatment, so Hispanics are are less likely to be treated for hypertension with a reduction in about 10%. And if you look also at control, if you're treated, you want to make sure that they are well controlled. So in comparison with non-Hispanic whites, Latinos have their hypertension controlled in 44.3% versus 56.4%, and that's 12% absolute difference there. Diabetes is very different, and also here it matters where the Hispanics come from. For example, different Hispanic groups have different rates of diabetes, and that has also to do with their admixture with Native Americans. We have seen here that Native Americans in this country also have high incidence of diabetes, but the prevalence is about 26% in Puerto Ricans, 24% in Mexican Americans, but then that drops to 15% among Cuban Americans. Mexican Americans also have a greater overall adiposity and a more unfavorable distribution of body fat with more central obesity. Their lipids, their balance of lipids, they are less likely, they have lower levels of HDL cholesterol, which is the good cholesterol, and higher levels of LDL cholesterol, and that relationship is unfavorable. And diabetic Mexican Americans have usually more severe hyperglycemia, higher incidence of end-stage renal disease and proteins in their urine, and higher prevalence of eye disease with retinopathy. So these are data from the San Antonio Heart Study that was conducted in the late 1900s, and you can see that the incidence of diabetes in this population has also increased. This is in yellow is a population that was recruited in the 1970s, and then that was assessed in 1987 after 8 years. So this is the incidence of diabetes, and then this is a second cohort of patients that were recruited a decade later. And you can see that the incidence of diabetes has increased significantly in both groups, but more so among Mexican Americans. So with all these uncertainties about Latinos, with one study in Texas, one other study in New York, in Chicago, one other study in California, and not lots of data. So there was a call from the NIH to conduct a study of Latinos, or the SOL study, that also means sun. So the study. The study was initiated in 2006, and it was conducted from the University of North Carolina in Chapel Hill as a central coordinating center. And then it included 4 communities with stable population of Hispanics, including Miami, Bronx, Chicago, and San Diego, and was supposed to recruit about 16,000 Hispanics aged 18 to 74 years of age. So there were many questions about Hispanics at the time. So the truth is that Hispanics had already become the largest minority in the U.S. And preliminary studies had also shown that despite their less favorable risk factor profile, with more obesity, diabetes, lower socioeconomic status, the cardiovascular mortality was actually lower in Hispanics, and that term was referred as the Hispanic paradox. And it has also been noticed that the longer Hispanics live in the U.S., the worse their cardiovascular risk factors become. So I think that that was a population of interest that needed to be studied. So one of the first publications that came out from the SOL study appeared in JAMA in 2012. That was after enrolling 15,000 patients. I mean, they enrolled more, but 15,000 patients were eligible for that analysis. And it was shown that there was the risk factor profile was different among the different nationalities of subgroups of Hispanics, with obesity and smoking being highest among Puerto Ricans. High cholesterol was also highest among Central American men. 80% of men and 71% of women had at least one cardiovascular risk factor. And then it's interesting because the prevalence of 3 or more risk factors was highest in Puerto Ricans, patients with less education, patients who were U.S. born or lived in the U.S. for more than 10 years, and that has to do with acculturation, and also that subjects that preferred English as their first language, and that also has to do with acculturation. So talking about acculturation, there are many factors that are involved in acculturation. So language preference, duration of U.S. resident, demographics, education, socioeconomic status. And the thing is that the more acculturated subjects will be more likely to smoke, to develop obesity, hyperlipidemia, hypertension, diabetes mellitus, and these are all cardiovascular risk factors that can increase the incidence of heart disease. the Hispanic paradox that we talked about. So that means that despite the poor socioeconomic status profile, the cardiovascular risk factor profile, some studies suggest that the cardiovascular mortality and overall mortality are lower in Hispanics than non-Hispanic whites. So the hypotheses that have been formulated for this, one is the salmon bias hypothesis, where Hispanics return to their home country to die, and consequently, these are not captured in census data and national death index. Then there's a healthy migrant hypothesis, where the more adventurous, more upwardly mobile Hispanics will move to the U.S. and therefore they're healthier, and then they are less likely to get sick. And then there's some other factors associated with psychological issues, like more social support, because they are more likely to be interactive and live with their families. Optimism and social ties among Hispanics may also play a factor. Less social isolation. So it seems that with increasing acculturation and assimilation, this potential epidemiological paradox may attenuate over time. But there's a lot of controversy in the literature about this Hispanic paradox, and some studies go against, and some studies go in favor. But the census data in general shows that Hispanics are less likely to have adverse outcomes compared to non-Hispanics or blacks in many epidemiological studies. However, the Hispanic paradox should not delay the development of interventions to improve the cardiovascular disease health in the Hispanic population. Another issue that we need to address as well that has to do with Hispanics is healthcare access and health insurance. So these are data from the Pew Research Center that shows that Hispanics who are not citizen or legal permanent residents are more likely to have no health insurance compared to legal residents and the general U.S. population. They are less likely to have a usual source of care, such as a primary care provider, and they are more likely to use emergency room, which is more costly, and it's a burden to our healthcare system. And so these are very, very important factors when developing interventions and taking care of this. So one of my research projects about 10 years ago was looking at what happens when Latinos are treated for heart attacks. And we published this paper in Circulation, and this was actually selected as one of the top advances for the year of 2010, and was highlighted research at the American Heart Association meeting. And what we found is that when Latinos do have access to healthcare, they're actually treated relatively well. And then we use these benchmarks of care, so how well they're treated, if they receive aspirin within 24 hours, if they are receiving aspirin at discharge, beta blockers, these medicines for hypertension called ACE inhibitors or angiotensin receptor blockers, counseling for tobacco cessation, or treatment for high cholesterol. So the rates were about the same. And then if you look at the mortality was about the same, 5.5% for Hispanic, blacks were 5%, and whites were 5.7%. Then this study also not only compared the mortality of Hispanics versus other ethnic racial groups, but also looked at the implementation of a quality improvement strategy to maximize the use of evidence care treatment. So this study had to do with this process improvement movement that was called Get With The Guidelines, where hospitals are encouraged to start and to start documenting the use of evidence-based medicines over time. And you can see that here, this is over time from 2002 to 2007, the use of aspirin, the use of lipid-lowering therapy, the use of beta blockers, and the use of all these medicines that have been shown and treatments that have been shown to improve outcomes in patients with heart attacks actually improved over time. And not only improved over time, but also in this slide, you can see that the gaps that we see here in the beginning between, the green is Hispanic, the black are in red, and whites are in blue. So you can see that the blue is at the top, so they are the ones that are getting all the good medicines. And you can see that in the beginning of the intervention, there are gaps. Those gaps tend to attenuate, and then at the end of the follow-up, there was no gaps. So implementing strategies to improve process of care in the hospital actually attenuate the gaps in treatment of ethnic and racial groups. However, we have to consider that these patients have already accessed the healthcare system. So these are not the ones that are left behind or are the ones that cannot access the emergency room. So there are some issues in racial and ethnic health care that we have to keep in mind, and these issues were well articulated by the Institute of Medicine back in the early 2000s in the publication Unequal Treatment. And it shows that cultural and linguistic barrier in which many non-English speaking patients report having difficulty accessing appropriate translation services. Well, this is not a problem here in Miami because there's a large proportion of professionals and in healthcare that speak Spanish, but that's a problem in other parts of the country. A lack of stable relationships with primary care providers. Minority patients, even when insured at the same level as whites, are more likely to receive care in emergency rooms and have less access to private physicians. There's also financial incentives to limit services that may disproportionately and negatively affect minorities. And there's also a fragmentation of healthcare financing and delivery. So in 2014, the American Heart Association came up with this science advisory white paper that is very important and is very, very comprehensive. And then at their conclusion, they came up with these three items, that there's an important impact of cultural and ethnicity on health behavior and health outcomes. I mean, we can talk for the rest of the afternoon if we go into each one of the health behaviors and health outcomes. This group also found that we need to tailor and develop culturally relevant strategies to engage Hispanics in cardiovascular health promotion, and that there's a need for a larger workforce of healthcare providers, researchers, and allies to cardiovascular health. And then there's a need for reducing cardiovascular disease in the U.S. Hispanic population. So here I conclude my lecture, and I would like to thank you so much for your attention.
So we'll have Dr. Myerburg now, switched over.
Okay, here's your clicker.
Can I use this one? Does this work?
That works. Let's see.
Okay, good. Good afternoon. So the issues of cardiovascular issues in athletes is complex. In one sense, the athlete has his or her own area of concerns and problems. And in the other part, they're part of an overall population. And what I'm going to try to do is walk you through these two components of athlete health and athlete problems. And I'm going to take a number of different approaches and try to integrate them. One is the incidence and causes of cardiovascular issues among two kinds of athletes, competitive athletes and recreational athletes. Most of what you see in the literature and in the media are about competitive athletes and the problems they've had. But the bigger number, as we'll get to in a little while, is the recreational athletes who have their own set of issues but are understudied in terms of how they are identified in terms of risk and management. Now, what are the cardiovascular issues in athletes? Well, the one that gets the biggest attention is sudden cardiac arrest and sudden cardiac death. And particularly when this occurs during competition. But one thing to keep in mind is that the athlete in competition is exercising at a lower level of activity or exercise intensity than he or she is during training. Training is the bigger problem. And there's another problem, which is the definition of sudden cardiac arrest and sudden cardiac death. Through the years, I've had the opportunity to talk to a lot of reporters individually about athletes who have died unexpectedly. And I've had this conversation about the distinction between cardiac arrest and massive heart attacks. And I can't tell you what a pleasure it is to have a whole room full of reporters here to make this point. Cardiac arrest is not a massive heart attack. Massive heart attack has sort of been moved into the media's lingo when referring to cardiac arrest. But a heart attack is what you heard about from the other speakers during the course of the day, and that is loss of heart muscle due to loss of blood flow to the heart muscle, which may or may not be fatal, may or may not cause a cardiac arrest. But cardiac arrest is the event that we're talking about when we're talking about athletes who die suddenly. And I hope you take this message back to your editors, because I haven't been able to make much progress in getting rid of that term. Now, how do we approach the problem? Pre-participation screening is the hallmark to identify athletes who have either unsuspected or unrecognized heart disease. And that would lead to then to how we approach them in terms of can they or can they not compete. And then we evaluate athletes, not the ones who've had a cardiac arrest, but the ones who are participating in their athletic activities, but develop suspicious symptoms. Chest pain, shortness of breath, wasn't present before, is present now. Whole host of things can cause this. Some of them are serious, some of them are not so serious, but they require our attention. So the evaluation of symptoms in the athlete who's already been cleared to participate is important. And then there's a question of guidelines for competitive athletics and recommendations for recreational athletes, which we'll get to in a little while. Now, I want to begin a little bit with numbers and what the incidence of the problem was. Let's start with the young competitive athlete, where most of the attention is on athletes' sudden deaths. So if we look at the risk of sudden cardiac arrest in young athletes less than 25 years of age who are competitive athletes, we don't know the precise numbers, but somewhere in the range of 1 in 33,000 to 1 in 100,000 over the course of a year, compared to the general population in that same age group, which is 1 in 100,000 to 1 in 200,000. So bigger numbers or higher risk in the athletes. Looking at adults over the age of 35, and these are generally the recreational athletes, in the adult general population over the age of 35, somewhere between 1 in 500 and 1 in 1,000, so 1/10 of 1% of the population have a cardiac arrest or die of a cardiac arrest each year. And if we look at competitive athletes in that group, it is 1 in 15,000 to 1 in 50,000. So the proportional risk in the younger athlete proportional risk for cardiac arrest is higher, and it's lower in athletes, in the older athletes, the recreational athletes. Now, there's a term I like to use. It's called the rule of 50s, just to give you an idea of what the cardiac arrest issue is in terms of population dynamics. So the rule of 50 says that about 50% of all cardiovascular deaths are sudden deaths. This is true whether we're talking about athletes, it actually may be higher in athletes, or non-athletes, and in the younger or the older population. 50% of those are the first recognized cardiovascular event. So the patient or the athlete had no knowledge of a cardiovascular problem before the cardiac arrest occurred in 50% of the cases. And 50% of cardiovascular disabilities resulting from sudden cardiac arrest with survival. So these are the CNS problems that develop after that. The disabilities, 50% of them are subject to or consequent to a cardiac arrest. So big numbers. Now, a little bit about classification of athletes and athlete risks, and there's 4 variables we look at. One is the type of activity. So there are competitive athletics, that's highly trained and competition type sports. Recreational athletics, which is what people do during the weekends, or either choose up basketball or jogging or whatever. And incidental conditioning, which is the question of doing treadmill work or something like that on an occasional basis. There is some data out there that says that if you do incidental conditioning and you're not doing it very often, and you start doing it, you have a higher risk of cardiac arrest during exercise or after exercise than if you regularly exercise. So incidental also has a time component to it. The intensity of the exercise, high, moderate, and low, I'll show you that in a moment. The age of the risk group, the young, less than 30 years of age, and middle, 30 to 45 years of age, and the older group, 45 years and older. And then the etiology, the cause of the athletic risk. There are acquired disorders. So one of the overlooked causes is a condition called myocarditis. So myocarditis is a viral infection of the heart. Subclinical myocarditis is very common just with a common cold. But for the athlete with myocarditis, if they continue intensive athletic activities, they are at an increased risk of having a significant heart rhythm problem and perhaps cardiac arrest while the myocarditis is active. So this leads to the recommendation that the athlete who develops myocarditis, and it's important to recognize when this occurs, should be restricted from athletics for 3 months after resolution of the myocarditis. Very important concept. Then there are developmental anomalies that are developed during fetal life, and one of them, for instance, is what's called an anomalous coronary artery. It's an artery of the heart muscle that's coming off the wrong place in the aorta, and with athletic activity, this can be a problem, and it's a big problem. Low incidence, but big problem because it's hard to recognize just with ordinary screening. And then there are inherited abnormalities. There's a whole host of them I'll show you in a couple of minutes that are disorders that are genetic in origin, that run in families, and for some of them, athletics is a trigger for a significant cardiac event, including cardiac arrest. Now, a little bit about classification of sports, and don't try to read this, but it should be in your handout. But basically, we classify sports based on 2 classes of parameters. One is oxygen consumption, which reflects cardiac output, and the other is the intensity of contraction, which talks about the strength of the heartbeat. And these 2 characteristics interact to create greater or lesser intensity-related risk of heart rhythm disturbances during athletic activities. I'll give you an example. The single most intense sport is rowing. Okay, it is not, and it's not the coxswain that we'll worry about. It is the rowers. But clearly the most intense sport, and a concern for people who have a propensity for cardiac arrest, either due to inherited disorders or acquired disorders. American football is here, basketball is here, baseball is all the way down here. So just to give you an idea, it's not just the major sports that we talk about, but things like rowing and cycling and canoeing all have intensities which are relevant to cardiovascular risk in the athletes. Now, there are different kinds of conditions that give us long lead times versus short lead times for fatal events. And this is about fainting spells leading to sudden cardiac death in adolescents and young adults, including athletes. So it's not just the athletes that we're talking about. So I'm not going to read off this whole list for you, but you can look them up. But basically, a lot of these are the inherited disorders or acquired disorders that become chronic. There are recognizable risks with shorter lead time. That's what I was talking about when I talked about myocarditis, if it's an active form of myocarditis, and other inflammatory disease, and drug-induced rhythm disturbances. And then those that are really difficult to identify, which we won't go into the details of in interest of time, but they are on your handout. So the American Heart Association screening tool has 14 elements to it. And they're separated into three components. One is the personal history. So this is a history of chest pain, fainting, exertional or fatigue, shortness of breath, a heart murmur, blood pressure, and so forth. The second category is family history. So premature or sudden death in people under the age of 50 in a blood relative is relevant. And disability from heart disease in close relatives. And then the identification of specific abnormalities on that list that I showed you before. And to a large extent, these are the inherited syndromes, but not exclusively inherited. The third category is what you pick up on the physical examination, which is heart murmur, the femoral pulses, and other abnormalities. Now, that said, the American Heart Association specifically does not recommend evaluation with a 12-lead EKG as part of the routine evaluation. It does say that if the 14-point screening is positive, then you should do an EKG. This is at variance with what's happening in the rest of the world. Basically, all of Europe and the Far East do EKG screening. And during the discussion, if you're interested, we can talk a little bit about what's going on in Japan, because that's really unique. So the question is the electrocardiogram a reliable and efficient tool for adding to the 14 element strategy? And so when we think about EKG screening, is it considering it as a routine part of clearance? What's the rationale? The rationale is to identify something we can't see on the history and physical examination and family history. What are the limitations? The EKGs in that age group generally, and in athletes particularly, are very hard to read. They have special characteristics, and you have to have experience in order to interpret them properly. There is the need for research, and to the extent that we do EKG screening, we can learn from research tied to that to improve the sensitivity and specificity of the EKGs. And then there's a debate about cost feasibility of these programs. I don't have time to go into the cost issue, just take my word for it, it's overstated. The added cost of just the routine 14-point evaluation is minimal. Now, what's happening in the United States? So, personal history, detailed family history, complete cardiac exam, high schools, colleges, and professional athletes, everybody gets the same thing. For the electrocardiogram, all professional athletes get screened with an EKG when they are drafted. College athletes are having increasing proportion of the athletes getting EKGs, but it's not uniform yet. And in high schools, it's virtually not done, except in the private high schools. The public high schools are not doing it because of what they're concerned about cost. And then echocardiogram is another element that's thrown in. Some of the professional sports are doing it. Colleges are generally not doing it unless something's abnormal on an EKG. And of course, the high schools are not doing it. Now, with this as background, recognize that the largest number of sudden deaths in athletes occur in high school students. And the second largest is in college, and the professional has the least. Now, is this the result of their screening or lack of screening? I'm not sure, but a lot of the high school kids who die suddenly have genetic disorders, and we may have missed an opportunity to pick those up by not doing routine screening.
Is that just because there's more people in high school than in college?
Oh, no. In absolute numbers is what I'm talking about. In incidence, the incidence is probably not very different. So yes, that's a good point. So now, symptoms of heart rhythm disturbance. In order to get into this, let me just define heart rhythm disturbances for you. So palpitations are usually what we call extra beats or premature ventricular or atrial contractions. There are episodes of racing hearts, which are runs of extra beats usually. It's a non-sustained tachycardia, sustained tachycardias, fainting due to heart rhythm disturbances, and cardiac arrest, which is uniformly fatal if not promptly treated. Now, in the American Heart Association ACC scientific statement on disqualification and clearance, PVCs are generally not a problem. Most kids with PVCs without structural heart disease will be cleared without any further intensive workup, perhaps exercise testing. Non-sustained tachycardias, and particularly ventricular tachycardias, are of a little more concern, and so they get a little bit more of a workup. But the bottom line on this is at the bottom of the slide. Non-sustained ventricular tachycardia is if it's suppressed with exercise, if there's no evidence of structural heart disease, no molecular or genetic disorders, and these are just transient abnormalities at the time of evaluation, can be cleared for competition. And that's important. The kids have to know that just because they come up with something on an EKG doesn't mean they're automatically going to be disqualified. Otherwise, they deny the EKG, don't get it. Then there's two other forms, sustained monomorphic VT, I don't have time to go into, but this can lead to clearance with appropriate treatment. And then the polymorphic VT, ventricular flutter and ventricular fibrillation. These are the things we really worry about. Most of these kids, if they experience this type of thing, will not be cleared. There can be some exceptions if there is a transient cause, such as myocarditis, which ultimately heals. Now, the final few points I want to get into is the question of recreational versus competitive athlete, young competitive athletes. So the red bars are young competitive athletes. This is showing the incidence of sports-related deaths in France at various ages. And then in the blue bars, we're talking about recreational athletes, some of which are in the same age group as the competitive athletes, but most of which are way out here. So you don't need to do statistics on this. The biggest problem of sudden death in terms of numbers is with recreational athletes, and particularly older recreational athletes. Now, why? It's because at the age of 35 or beyond, that's when these individuals begin to develop coronary artery disease, and then the coronary artery disease progresses as time goes on. Autopsies on kids who die suddenly are extremely important, particularly under the age of 35. And if there's no structural heart disease, there's a move afoot to do postmortem genetics as a routine to see if the family carries any gene, or the victim carries genes which may reflect back on other family members. The point being that genetics in situations like this are just as important for the surviving family members as it is for the victims themselves. For the victims themselves, it just confirms what we might have thought. For the family members, we can find other affected people. I won't go through this. This is just recreational athletics. So pre-participation evaluation of recreational athletes, we have not done a very good job with. So there's no specific guidelines for competitive athletics in the recreational group, despite the higher numbers of sudden death than in the young competitive athletes. And the individuals with known cardiovascular problems or uncertain symptoms should be evaluated by their physician and prescribed appropriate level of activity with appropriate screening for what the physician can elicit about family history, about symptoms, about the various things in the 14-point scale of the American Heart Association. So once that takes us to the point of what can we do to identify and predict and perhaps prevent, now it's a question of what do we do when something happens. So the other area that has received a great deal of attention is the availability to respond to life-threatening situations in athletes in school and in other sports arenas or areas. So, number one, be prepared, which means basic life support has to be available during training and competition. A lot of high schools now are training the coaching staff and teachers to do CPR. Automatic external defibrillators at training sites and stadiums and arenas. Again, the training of people to use them. There's a rule of thumb in schools now, not written into law, but it's the one thing we kind of hang on to, that an external defibrillator should be within 5 minutes of any point on the school property, so that if you're giving CPR, you will have a defibrillator there within a few minutes. The second is to respond rapidly. So evaluate the unconscious victim immediately, look for pulse and breathing. If he's not, start CPR in 2 minutes or less. Call 911 if they're not already on the site, and deploy the AED as quickly as possible. So that's the story of the sports, both for the competitive athletes and the recreational athletes. And thank you for your attention.
So we have a good amount of time for questions. I would whoever wants to start, maybe you can ask general questions, but maybe keep it targeted to, a comment to one of them specifically. We'll go to Alex and then Jackie. And his son. And then we'll go over to Amanda.
Hi, Dr. Myerburg. Thank you for your talk. I wonder, does like the emotional stress or, kind of excitement of athletics play a role in like the cardiac arrests or these events?
Can I have another half hour? So yes and no. I'll give you an example. The Northridge earthquake in California in the 1990s. The people at the site of the earthquake, there was a 3 to 5-fold increase in myocardial infarctions and cardiac arrest in the people on site at the site of the earthquake compared to what had happened over the prior 5 years on the 2 weeks before and after. So they did a really comprehensive analysis of what was different on that day than on other days. These were people who were on the scene. What this tells us that acute stressors can be a trigger for cardiac arrest. What it doesn't tell us is whether chronic stressors give us a predisposition to cardiac arrest. The other point on that is 9/11. So in 9/11, there was an increased incidence of shocks from implanted defibrillators in patients in New York City. I'm sorry, I stated that wrong. There was not an increased incidence. But these were not people who were located in the area of 9/11. These were people in other parts of the city. So they didn't have the same level of stress, presumably, as the people in the part of the city that had it. And the same thing happened in Israel with the Scud missile attacks. There were some increased numbers of sudden deaths. So the short answer to your question is yes, acute stressors can trigger a cardiac arrest in the susceptible individual.
So you're saying not necessarily in like the young athletes who are like in the middle of competition?
Well, if a young athlete is susceptible because he has an inherited long QT syndrome, yes, yes. But young athletes per se, no. They don't undergo that same kind of stressor.
Okay, thank you.
Over to Jackie.
Hi, this question is for Dr. Mauricio. I didn't get it quite well. Did you say Latinos have a higher risk of diabetes or heart disease? If you can explain a little more about that.
Yes. So Latinos, depending on the Amerindian admixture, have higher risk of diabetes, and the incidence and prevalence of diabetes is twice of Caucasians or non-Hispanic whites. Then the risk of cardiovascular disease is higher, but yet they have a lower mortality because of that Hispanic paradox that we're trying to understand.
Can I just, one more question? I don't know if this has to do, last time we had another fellowship where they said that Latinos tend to live longer. And some of the causes, they were saying that it's because we tend to eat more at home. We don't, mainly immigrants, they cook more at home. They don't eat so much fast food. So I don't know if this has something to do, but it's interesting.
That also has to do. I think that there's a social cultural component where there's more social interaction, and then I think Hispanics are more content with families at home, and they also bring tradition cooking with more whole foods than highly processed foods in the U.S. And the longer they live in this country and the more acculturated they get, that's when, with all the cardiovascular risk factors, the obesity, the unfavorable lipid profile, they become like a time bomb.
Thank you.
Hi, Dr. Myerburg. You mentioned the thing about you're trying to get AEDs within 5 minutes of wherever athletes are. How compliant are places with that? Is that working out? Is that something that's pretty consistent, or is it?
That's really an important question. I don't know the answer to that. The way this emerged was as we meaning the community that's interested in this, began to get involved in schools and what should we be doing. There was an arbitrary decision about this 5-minute rule. I don't know of any data that says that that's good enough. It's entirely possible that 3 minutes might be better. Let me talk about reality. The reality is that in sports venues, whether you're talking about in schools, colleges, or in professional athletics, in today's world, these things are right at the site. So they are immediately available, and there are trained individuals. So the reality of it is that, they are there and available for those that have them. What I can't tell you is what proportion of school. I'm really concerned about the high school problem because it's not getting the attention it needs. And I don't know what the actual numbers are for that. In terms of training, I do know that there's a lot of pressure on the schools to at least have the AEDs and trained responders available, even if they don't do EKG screening.
Just a quick follow-up. What about kids who do maybe community sports that aren't in a controlled, like the school?
Well, kids who do community sports fall into the category of recreational athletics. Mm-hmm. They're completely different than the trained athletes.
Other questions? So we'll go to Sonia and then Patty.
My question is for you as well. So I've done a lot of stories on hypertrophic cardiomyopathy in kids. And so where are we now? Because I know a lot of kids get screened and it's part of the process, part of I don't know if it's as young as, it's usually middle school, right? When they start these screenings.
It depends on what country you live in.
Okay.
Okay, but it's usually high school in the United States.
Is that early enough?
Pardon?
Is it early enough, soon enough to do that screening?
Okay. I was hoping somebody would ask that question. So let me tell you what happens in Japan. In Japan, they started a program a number of years ago where kids entering grade school would get, as a part of a physical examination for medical status and entering grade school, an EKG. And then when they got to middle school, they got another EKG. They then went back and looked at the incidence of diseases that are inherited that can cause sudden death, and particularly long QT interval syndrome. And what they found was that in Japan, based on their system, the incidence of long QT was twice what it is in the United States and Europe. There's no reason to believe on a genetic basis that that's true. What is reasonable is that they're able to recognize these because they're doing these early EKGs. They even paired up the EKGs with genetic testing. They did a beautiful job. Now, you put that together with the fact that people with long QT between birth and age 40 have a 13% mortality rate if untreated or unrecognized. And so if we're missing half the cases because we're not screening, there's a lot of unexplained deaths that may be occurring that we are missing. I'm really impressed with what the Japanese are doing, and I hope to see it graduate to here.
Who pays for that, though, in Japan? Who pays for that in Japan? Do you know?
I have no idea. You know, I read the papers. I wasn't paying attention to the funding. I suspect it was the government.
Dr. Goldberger, I was really surprised to hear that with atrial fibrillation that we still don't have very good methods of treatment for something that seems, not very rare, that's been around for a long time. Can you talk about why that is? And if it's lack of research, why isn't it being researched?
So that's a topic for another long discussion. There have been attempts to advance treatments for atrial fibrillation. There are really two main camps of treatment. So one camp says we got to restore the rhythm back to normal and get the rhythm to be normal. And the other camp says just let it be. Atrial fibrillation is okay. You can live with it. And there's partial truth to that. And it's been hard to prove the other way around, that restoring the rhythm back to normal is actually better. But I think we've now accumulated only recently data and information to at least support that. So there's sort of a little bit of a lackadaisical attitude in the medical community at large about atrial fibrillation. It's also a very challenging arrhythmia to treat, and that part goes also back into why it's been hard to show that there's a benefit to treatment. Many of the antiarrhythmic drugs, the medications that we use, are just not very effective. Efficacy rates of 20, 30%. It's terrible to go to your doctor and say, yeah, you could take this drug, but it only has about a 1 in 4 chance that it's going to work. Catheter ablation, similarly, people have tried to come up with ways to improve the catheter ablation procedure. Most of the approaches have been if this much ablation is not working, let's do more. There's a limit to that because the more tissue you destroy, the less the heart's going to work well. And so I think we need to sort of step back and look at some of these other approaches and figure out better ways to actually treat it. So it does require a little bit of a paradigm shift from decades of poor thought regarding atrial fibrillation.
Are you saying that lifestyle changes may be really the best bet because of weight loss? What you said about that?
So just like my colleague over here, when he puts a stent into a patient, he doesn't send the patient home without giving him good instructions about lifestyle, putting him on a statin medication. I think eventually we're going to be doing the same thing with atrial fibrillation. It's going to have to be a more comprehensive approach than just doing a one-time procedure.
Marisa?
Hi, Dr. Goldberger. Can you explain a little bit more about the people who take the liraglutide and who qualifies for that? Is it just people who are diabetic, or I can't remember.
Yeah, thank you. So, no, the trial is actually open to patients who have atrial fibrillation, who want to have an ablation procedure, and are overweight. That's really, it's very simple. The drug is approved by the FDA for both diabetes and for treatment of obesity. So it's already approved for that indication. So, it's a very simple design for the trial.
Thank you.
Any other questions? Sandy?
Dr. Goldberger, I didn't quite understand how obesity triggers AFib. You said something about the fat leaking bad humors. That's interesting. What are bad humors and what's that direct connection?
Okay, so yeah, nobody really knows for sure exactly how obesity leads to atrial fibrillation. We have a lot of data, a lot of studies that have shown that it is a risk factor for atrial fibrillation. And you could come up with many different ways in which it might induce atrial fibrillation. What I was talking about is the fat tissue that sits right on the heart. It's the genes in the fat tissue can actually be stimulated under certain conditions to start to release substances. They're called adipose cytokines, which just means proteins that are made in the fat tissue that can actually promote fibrosis in the atrium. Fibrosis is actually a key factor if you look at the histology or pathology of the atrial tissue in patients with atrial fibrillation. You see fibrosis. And that gets back. So that means the muscle tissue gets replaced with fibrous tissue instead of muscle tissue. And what the fibrous tissue does is it creates the electrical impulses. They can't pass through fibrous tissue. So it creates all sorts of circuits and possibilities for atrial fibrillation. But that also gets to your point about the way we think about atrial fibrillation. If atrial fibrillation is a disease that's due to fibrosis, what catheter ablation does is it creates more fibrosis. So we're essentially treating a fibrotic disease by creating more fibrosis when we do ablation. And that's why we have to sort of step back and look at some of these other interventions that might actually benefit.
Bill?
Thanks. It seems like every hospital down the street is opening up electrophysiology labs. Is it a good thing to spread this, or is there any, what's the expertise needed? Should it be consolidated more in centers, or should every community hospital be doing this?
Is that to Dr. Myerburg or to me?
On electrophysiology for AFib, catheter ablation, those kind of things.
It's really a tough question. I think you want to be able to offer. What? Okay. No, you want to be able to offer services, and I think for a lot of what electrophysiologists do, there is a bread and butter piece to it that I think can be widespread. I think that every lab opening up and doing atrial fibrillation ablation has not been helpful in advancing the field and in coming up with new and better ways to do it. I think you could talk to 10 different electrophysiologists and find 10 different approaches to doing atrial fibrillation ablation. And when you find that much diversity, it just means we don't know what we're doing yet. And to bring something to the public without knowing better what you're doing, is probably not a good idea.
There's issues about skills and quality of performance, things like that come up. This is a general problem, but specifically for electrophysiology. And I think what we desperately need is some way of evaluating labs to say this is what they should and shouldn't be doing. So certain levels of electrophysiology might be very well dispersed throughout the community, and others should maybe be one or two places in a general area. But the main thing is to make sure that the people providing the service are qualified to provide what is some very sophisticated services.
There's always a volume outcome relationship that
Yeah.
applies in general to many of the procedures we do. I mean, that volume outcome relationship was initially studied in surgery and now is applicable to these procedures. I think that I'm an interventional cardiologist, and to me, the procedures for AFib ablation are very complex. And I think that there's an experience that is needed. So I think professional societies and I think they need to make sure that we track outcomes and we measure what we do so we can learn from it.
Absolutely.
And also track complications and track successes. So we know exactly what we're doing right and what we're doing wrong. And in some instances, not for AFib ablation that I know of, but some programs have been closed after tracking outcomes. And I'm not saying for AFib ablation, but for example, for CT surgery, for cardiothoracic surgery, some programs have been closed because the outcomes were unacceptably bad.
Dr. Cohen, I wonder, I mean, the definition of Hispanic just seems so wide. I mean, it would cover such a huge, variety of people. Is there a lot of research that kind of digs into the genetics of different groups? I mean, how people whose ancestors come from Spain might differ from Peru or from other places?
I didn't plant you out there.
I gave a similar lecture when I came to interview here at the University of Miami, and that's exactly the question that Dr. Myerburg asked. There's a number of genetic issues being studied now. There are within the Hispanic groups. I think that the study of Latinos have collected samples. I'm not aware of any specific differences, but just look at the phenotype, the phenotypes of the different Hispanics, and you can tell who has more diabetes, who has less diabetes, and you can imagine that there's a different genetic composition for these different groups. There's a multi-ethnic study of atherosclerosis that looked at African Americans, non-Hispanic whites, Asians, and Hispanics. That is also looking at all the differences between these different ethnic racial groups.
So the short answer to that is, for many of the conditions, and particularly the genetic disorders that we deal with, we need control groups that are specific to origin of groups of patients, so that people from Finland and people from France do not carry the same complement of genes. One of the more interesting aspects, and it really is troublesome that this even happened, has to do with hypertrophic cardiomyopathy in blacks. And there has been long noted that hypertrophic cardiomyopathy is more common in the black population. A study came out from Boston about, 4 or 5 years ago that looked at some of the genes that were identified in the black population associated with suspected hypertrophic cardiomyopathy, and these patients were labeled as hypertrophic cardiomyopathy because those genes were not present in normal populations. The problem was that the normal populations they used in those days were basically white populations, European origin, and largely Scandinavian origin as well. So these investigators went to Africa, to sites of origin of the people who carried these genes, and found out that these were the common benign variants in large segments of those populations, and they didn't indicate the disease. The message there is that we've got to be very specific about how we look at control groups. They have to be very specific for the population we're studying, and not just, a general control group tells a story for everybody. It does.